Hello everyone. Today we are going to be discussing about a very common condition, especially among children and then the adult, which is known as the asthma. And asthma is a kind of actually chronic disease involving the airways in the lungs. These airways, or to say bronchial tubes, allow air to come in and then out of the lungs actually. So someone who is a kind of asthma is having his airways always inflamed. That is always having a kind of inflammation, right? Because it's a kind of chronic disease. When we say chronic, something is chronic, it means it is taking a long time, right? Yeah, it has been a long time, not within a short period of time. So actually, uh, for a person to get asthma, actually, that is now we are going to talk about the risk factors. We have seen the definition, then the risk factors of asthma of being having contracted with asthma. That's risk factors. The risk factors. So actually, the risk factors of asthma actually we have family history. Family history. For example, in your family, if someone is having asthma, so there is chance of you also are going to have asthma actually. So you see, it is a kind of something that is running in the family. So that is because of inheriting of some kind of actually genes, right? So number one. Then another risk factor is also a kind of, for example, maybe during pregnancy during pregnancy. Because if a lady is pregnant and taking some kind of drugs like drugs, for example, like for ulcer treatment, for example, H2 blockers like proton pump inhibitors. So these drugs, when taking them during pregnancy, they are putting the child at risk of having asthma during his childhood, right? So, but this they are not the definitive cause, but they are putting the child at risk because so many people are taking the drugs actually without their child being having the asthma, right? Or the asthma like attacks, and also if someone is a kind of having a like recurrent episode of infection of upper respiratory tract infection, that will also put him at risk of having this asthma. So now let us see the pathophysiology of asthma. So what is actually happening in the asthma? That is the pathophysiology. So in asthma, actually pathophysiology, whatever is the cause of the asthma or whatever the risk, the airways, let us show the airways again. This is called the trachea. This we have the primary bronchi, the two primary bronchi. We have the secondary bronchi, that the secondary bronchi. Then we have the bronchioles separating. So that's sprouting up. So actually, this in asthma, this kind of airway become narrowed, right? All the bronchial tree become narrowed, very narrowed. So if they become very narrowed again, plus in addition to the narrowing of the airways, then they are going to be filled with mucus. So that is exacerbating the lumen. That is making it even more narrower. This is the lumen supposed to look like. This is they zoom it out. So this is now in asthmatic patient it become like this, right? See the smooth muscle. This is muscle that are found around the. See how the muscle looks supposed to look like. But now in asthmatic patients they become very thick. So now narrowing the airway. See, right? Because airway will going to be very hard in passing through this in and out than in this, because this the resistance is very less. Then air will going to be moving freely here, but here it's narrowed, right? So in asthmatic patient, this is what is happening actually. And then now we are going to see the types of asthma. The types of asthma, that is the pathophysiology. We see it is due to narrowing of the airways, and then plus secretion of mucus, making the narrowing even more, right? So that is it. So now we are going to see the types of asthma, because depending on the cause, they are divided into three actually. Number one, we have atopic asthma. Number one, we have atopic. Number two, we have non-atopic. And then number three, we have drug-induced asthma. drug-induced asthma actually. So these are the 3 types of asthma we are having. So actually, this for the atopic asthma, when we say something atopic, it is regarded to, as allergic reaction. It's a kind of allergic reaction, and it is the most common type of asthma we are having. Most of the patients that are having asthma, they have the asthma due to this atopy. It is known as the atopy. When we say the atopy, right? And it is even regarded, this atopy is from the word atopy. Atopy means something which is hypersensitivity. It's known as the atopy, and it is even divided into 3 triad. Someone with asthma, this is triad. We have allergic asthma, we have allergic eczema, that's the allergic dermatitis, eczema, and then allergic rhinitis. So this is a triad. So someone with this eczema may likely to have this or this. Someone with this asthma, if it is due to this atopy, he may likely to have this dermatitis, that is the eczema, or allergic rhinitis. Allergic rhinitis is just like it is having a symptom of common cold, but it's not due to infection, but due to like allergen, for example, like dust or something like that. So, but the symptoms are almost the same with the common cold. So these are the triad. It is hardly to find someone with one of these 3 atopies that they didn't have the other one, or didn't have both the other 3. So this is the atopy. So this is the most common factor that's seen with asthma. And what is happening here is actually if someone is having allergic to he's having allergic to some kind of particle, for example, let's say dust particle, for example, or like this. For example, if he's having a kind of allergic to this, so his immune cells will develop a kind of antibodies against that particular allergen, right? So if his immune at first time when he is sensitized to that particular dust, then his immune system will develop an antibodies that is specifically IgE, because IgE is the most important antibody that is participating in allergic reaction. So this IgE will go and actually kind of attach to mast cells, because mast cell is a kind of also immune cell that is participating in allergic reaction. So when this, for example, let's say this is the first time he sensitized to this allergen, then the second time when he is exposed to this dust again, then this IgE will stimulate these mast cells, and then mast cell will produce a kind of histamine, leukotrienes, and then eosinophil activating factor. Then it will activate eosinophils. You know eosinophils. So these eosinophils, because it is allergic reaction, you will also see eosinophil. So when this histamine, the most important factor here is the histamine and the leukotrienes, because it is the histamine and the leukotrienes that make that airways to become very narrowed, and then stimulate the production of that mucus in the airways, so making the airways narrow. So this is the pathophysiology of what is happening in atopic asthma actually. So now we are going to move to a non-atopic asthma. Non-atopic. So in non-atopic asthma actually, the causative agent here or the etiology is unknown, is idiopathic, right? But just the scientists or the medical doctors actually are suspecting a kind of viral infection that is preceding the asthma attack. For example, like we can say the asthma attack is caused by the person may have a history of having a kind of upper respiratory tract infection due to virus. For example, like viral, because as we have already know that the most common cause of common cold, that is the 99% is caused by virus, right? So the person who is having asthma due to this non-atopy, which is not due to allergic reaction, may be having a kind of preceding viral infection, which is preceding upper respiratory tract viral infection, that is common cold. So this will exacerbate the asthma, will cause the asthma actually. So we have the third one, which is called drug induced asthma. So this is caused by drug induced asthma. So the number 3. So this drug induced asthma actually, as the name implies, it is actually induced by drug actually. So the most important drug we have to be knowing, and any asthmatic patient is not suspected to be taking this drug actually. So whenever he is required to be prescribed this particular drug, especially this aspirin, because aspirin is an NSAID, right? And any NSAID will block the production of prostaglandin. That's by blocking COX-2 enzyme. We have COX-2 enzyme, circular oxygenase, and this COX-2 enzyme is using a kind of metabolite called arachidonic acid. Arachidonic acid. So this COX-2 will take this arachidonic acid to be producing prostaglandin. And then we have also another enzyme called lipooxygenase. So lipooxygenase is also taking arachidonic acid to be producing a kind of leukotrienes. So when you block this COX-1 and COX-1 and COX-2, we have two types of COX. So the aspirin is not specific, so it is blocking both the types of COX. So actually, this aspirin, when it blocks the activity of this COX, so definitely this arachidonic acid will going to be used up. All of it will going to be used in the production of leukotrienes, because by blocking this COX, you block this pathway. That is no production of prostaglandin. So now you didn't block this lipooxygenase. So now the lipooxygenase will going to be taking hold arachidonic acid and then producing this leukotrienes. And as we have already know in the pathophysiology of asthma, leukotrienes is playing a huge role in the production of that mucus and the narrowing of the airway, right? So this leukotriene will now go, and because it is produced in excessive amount, will now go and cause the narrow and mucus production. So this means the prostaglandin production and then the leukotriene production has to be balanced. But now you block one, you didn't block the lipooxygenase using this aspirin. So definitely the pathway will shunt down toward this leukotriene. Leukotriene will going to be used up, because now there is a lot of arachidonic acid to be used in the synthesis of this leukotrienes. So this is the drug-induced asthma actually. So now we are going to see the signs and symptoms. Signs and symptoms of asthma. So with the signs and symptoms of asthma, actually, number one, any asthmatic patient is having a kind of dyspnea, that is shortness of breath. This is the most common complaint, shortness of breath. So he will going to be having trouble with breathing, and he will be going to have cough because of the mucus that is produced in the airway. So that will stimulate cough, right? And then the person will be experiencing a kind of chest tightness, right? So the person will be experiencing a kind of chest side tightness actually. So these are the most important symptoms of asthma actually. And you as a doctor, when you take his blood, especially if the attack is very serious, if you take his arterial blood gases, you will see that he is having a kind of hypoxemia. That is a lab, arterial blood gases, APG. If you take that, you will see that he is having a kind of low oxygen, because now the air is not going in due to the narrowing, so he will definitely have less oxygen in his blood, right? So this is it. So now we are going to talk about treatment. So as we have already know that any disease which is having a kind of exacerbating factors like asthma can be exacerbated by anything. So before we move into the treatment, we have to kind of counsel the patient so that to avoid the exacerbating factors. So now the prevention before we talk about the treatment. Before you give him drug, you have to counsel him to avoid using perfume. Avoid perfume actually, because perfume can trigger the asthma attack. Avoid perfume. Then avoid going to anywhere that is kind of having smokes, and like dust. And also if the asthmatic patient is having a kind of problem with cardiovascular system, like having hypertension, we know that hypertensive patient used to be prescribed with propranolol. So avoid prescribing propranolol to someone who is having hypertension and then having asthma, right? So avoid prescribing the propranolol to that people actually, because if you give them propranolol is a kind of beta blocker, and then we already know that in the airways we have beta receptors. These beta receptors, they are the one that keep the airway to be open like this. So if you give them beta blocker, especially someone who are having the asthma, so now this propranolol will make their airway to become like this, especially the asthmatic people. If he is not having asthma, then the effect is less. So, but for asthmatic patients, they are kind of hypersensitive. Then this propranolol will cause increase in the narrowing, right? So it will make their bronchial airway to become like this. So actually, so you have to. So for the treatment, so you have to avoid this. So for the treatment, actually, prescribe a kind of salbutamol. This is the most important drug used, salbutamol. So this is the most important drug that is used for asthmatic patient. So thank you very much.